Okay, so thank you everyone for joining us today for our Teach Educational Rounds on tobacco interventions for clients living with an acquired brain injury. Our faculty today are Dr. Peter Selby, Carolyn Lemsky, and Tim Godden. Are you interested in obtaining a letter of completion for today's Teach Educational Rounds? If so, please make sure that you had registered for the webinar and completed the pre-learning assessment. You must be signed in to view the live session with your full first and last name, and you must complete the evaluation and post-learning assessment that will follow today's session. These webinars are being live tweeted on Twitter, so follow us at #TSQuitSmoking, and we are using the hashtag #TeachWebinar. Our presenters today, Dr. Peter Selby, is the Director of Medical Education and a clinician scientist at the Center for Addiction and Mental Health. He is a professor in the Departments of Family and Community Medicine, Psychiatry, and the Dalla Lana School of Public Health at the University of Toronto. Carolyn Lemsky is a board-certified neuropsychologist with 25 years of experience working in rehabilitation settings in the U.S. and Canada. For the past 15 years, she has been the clinical director at Community Head Injury Resource Services of Toronto, a Ministry of Health and Long-Term Care funded agency designed to promote community reintegration of persons living with the effects of acquired brain injury. And Tim Godden is currently an advanced practice clinical leader in the acute care program of CAMH. He has worked in the fields of mental health and addictions for the past 27 years, providing therapy, supervision, and training across a variety of practice settings, including intake assessment, Aboriginal, brief treatment, concurrent disorders, drug treatment, court, and rainbow services. These are our disclosures and our faculty disclosures. The TEACH curriculum and slides were developed and compiled with funding from the Government of Ontario Ministry of Health and Long-Term Care. Content of slides are primarily based on the following guidelines. These materials, as well as the verbal presentation and any discussion, set out only general principles and approaches and do not replace the need for individualized care. So before we get started, we're going to do a few polling questions just to gauge who is joined us today. Okay. So on the computer, please indicate what region your organization serves. Okay, so it looks like the majority are from the GTA. Our next question. Please indicate if you work for one of the following. If other, please type this into the chat box. So it looks like it's an even split between hospitals and some other types of organizations. And our last question. Please indicate your discipline. You may have to scroll down to the bottom to see more options. And if other, please type into the chat box. So it looks like most are registered nurses. Thank you, everyone, for answering those questions for us. We'll hand it over to our facilitators now. Carolyn, if you are starting us off, just make sure you unmute your line by pressing *1.
Okay, I think I'm on mute. Can you hear me?
I can hear you. Just want to check, and everyone else hear Carolyn okay? Great,
Okay,
thank you.
Great. I'm seeing some yeses here. So our learning objectives today are to look at how cognitive impairments might alter the approach to tobacco cessation and give some consideration to adapting mainstream treatment programs using a case-based approach. And we're hoping that that's going to be pretty interactive. And we're going to develop a cessation treatment program using a case-based approach. And today, Natalie Brown from PRI, I noticed that she's here, has provided us with a case that we're going to be using. And so those slides were developed by Natalie. And at this point, I'm here. So just to start you out with a couple of facts related to the relevance of smoking cessation to folks who have acquired brain injury, there is evidence that having sustained a brain injury increases the likelihood of smoking. And most of that evidence is from cross-sectional studies. And in particular, Gabriella Ely did an analysis of some Center for Addiction and Mental Health data that were collected in 2011 as a part of a Center for Addiction and Mental Health representative survey of adult mental health and substance use in Ontario. And what she found was that about 17% of that population reported a history of brain injury with at least 5 minutes loss of consciousness or an overnight stay. And those who reported an acquired brain injury had twice the risk of being daily smokers. And similar data were found with kids, even when their injuries occurred quite early, that they were at increased risk for developing mental health and addictions issues, including nicotine dependence. And I think it's pretty common knowledge among folks who are working in smoking cessation that a group that's highly affected by and uses a lot of tobacco are folks living with concurrent disorders. And when you look at the brain injury history in that group of very complex individuals, you find that nearly 70% of them will report some history of acquired brain injury, and a similar proportion will also report cognitive impairments or neurocognitive impairments. So not only does brain injury increase the likelihood of having a dependence problem, but some of the most complex folks that we're seeing for smoking cessation also have a history of brain injury and neurocognitive impairment. And it's easy to imagine, and we're going to talk a little bit about this, that individuals who are cognitively impaired often may suffer the most sort of psychosocial problems as a result of their tobacco use. I know at Cheers we're well acquainted with individuals who have lost housing as a result of unsafe smoking and an inability to follow rules. And some folks, in the case that we'll present today, maybe have left needed treatment because of their smoking. We have known this to be true for smoke-free addictions programs, but also, in this case, actually brain injury rehabilitation. Well, if you think about it, and really all we're going to have time to do today is to sort of allude to the many ways in which changes in cognition can affect both the acquisition of a tobacco dependence, but also the treatment of the tobacco dependence. And the primary road through which that happens is emotional dysregulation. And the changes in the tissue, and this occurs even in mild traumatic brain injury, between the frontal lobes and the centers that actually perceive and process emotional information deep in the temporal lobes is often disrupted, and that can cause temporary or lasting emotional dysregulation. And one of the things that is a well-established pattern or understanding in the field of brain injury is that if you have difficulties with emotional regulation or some sort of mental health problem and subsequently you have an acquired brain injury, you don't seem to recover as well. So the matter of emotional dysregulation and brain injury are really very intertwined, and increased likelihood of mental health and addictions issues after brain injury, and also having those issues put you at risk for acquiring a brain injury and also for having a less complete recovery from brain injury. And it's the increased impulsivity and the changes in emotional regulation that may make a person more likely to become tobacco dependent. And then, of course, there's cognitive impairment. I won't unpack this in just a second in some more detail, but if you think about the process of helping to intervene with somebody who's in smoking cessation and they have difficulty with memory, they may have difficulty in representing their own experiences accurately, but they may also have difficulty remembering what's occurred in therapy sessions or have difficulty in following through. And the same is true for attention. And in this case, we can think about attention being most problematic when a person has difficulty in ignoring the kinds of stimuli that may be triggers for smoking, or becoming hyper-focused on them. And then, of course, executive dysfunction, difficulties with planning and organization may make it more difficult to follow through in a coherent fashion with any recommendations that are made. A person who has difficulty with self-awareness may not be fully aware of all the impacts of their smoking or their other behavioral issues that may have an impact on the intervention for the smoking cessation. So you can see how this becomes a very complicated situation. And on top of all of that, there may be some just primary difficulties in communication, difficulties with word finding, and difficulties with understanding what's being told to them in a session because speed of processing is slow, or there may be an auditory processing impairment that just makes it difficult to parse the messages in language. So this is an interesting schematic that we could probably talk about all day. It's a model that comes from a very interesting, actually, set of papers by Felstein and Associates, this one particularly from proposed model of neurobehavioral mechanisms that underlie psychosocial alcohol interventions. And the example in that paper was motivational interviewing. So what we're looking at here is a theoretical map of what it takes, what brain structures do you need to have intact to benefit from motivational interviewing? Which parts of the brain muscle are being exercised when you're in the room with a client? And so I'll call your attention here and to the right side upper, where we're looking at a schematic of the frequency with which different parts of the brain are damaged as a result of traumatic injury. And so we can think of this as kind of a classic graphic that's used. It's based on 100 cases, consecutive cases, and each circle represents a traumatic injury. And what you notice is that the areas that have the most circles or the most densely colored are right over here in the frontal lobes, the supraorbital cortex, and the temporal lobes. Now, that machinery is really highly involved in executive function, particularly behavioral self-control, insight, awareness, and the processing of emotional information. So you look at how this traumatic brain injury maps onto those areas of the brain that are most active in the process of addictions therapy, and in this case, motivational interviewing. And what you notice is that the dorsolateral prefrontal cortex and some of the other areas here that are right in the front, they may be slightly less affected. So a person's able to sort of talk a good game, and they can respond to some of the questions, but often the problem deeper in the brain, and these areas of the brain are very quickly, responsible for doing things like reflecting on personal history, processing the balance of rewards and punishments. Those very complex calculations that have to be made on a social basis as well are in areas of the brain that are much more likely to be damaged. And I'll call your attention particularly to this orbital frontal cortex. So what you see is that in session, a person may be able to do the rational reasoning. They may have a little bit more difficulty with the emotional learning memory or coming up with the content based on their own emotional or memories and literal memories, have difficulty in processing rewards. But in particular, when it comes to behavior change, that executive control piece may be missing. So one of the things that you often see with a group of folks who have had some difficulties with brain injury is that what they say and what they do is a larger gap. And this, I included this slide only just to illustrate that the model that's proposed in that paper is developing a lot of, or accruing a lot of support in the research. And what we know is that the brain lights up much more to self-generated versus experimenter-generated change talk and sustained talk. And that, of course, fits with our understanding of how motivational interviewing works. But, and this is just one simplified thought, is think about it, if a person has greater difficulty in accessing their own memories and accessing them with a full awareness of their emotional content, they're necessarily going to have a greater difficulty in benefiting from this kind of an intervention and are likely to need some additional supports in doing so. And so I'm going to talk, I'm going to pass the presenting to Tim, who's going to talk a little bit about how these kinds of impairments have an impact on the four processes of motivational interviewing and some of our thoughts about modifications that might be useful.
Before Tim takes over, Grace Creepers has a question, and I don't know if you can see that, Carolyn.
I can, but it was hard for me to pay attention to it.
Yeah.
So I have a client who had brain injury at brain surgery at age 12 for benign tumor. Mood changes reported by parents, and she's now 26 years old, with high mood dysregulation, impulsivity, and addictions. Never thought to connect it to the surgery, but do you think it could be related? And the answer to that is, yeah, definitely. We see a lot of tumor survivors, and it comes in two pieces. One is the part of the brain that's affected, and also the process of being the treatment that's applied, in some cases chemotherapy, and in some cases radiation. So that also can have an impact. And then the traumatic experience of having been a brain injury survivor. And sometimes going back to a school situation that may not fully accommodate the new kinds of issues that they've got. So the situation's really complicated. It's trauma on a few different levels. And so the emotional dysregulation that you're observing is probably a combination of all of those factors, if that makes sense.
Okay. Thanks, Carolyn. So, and thanks for the question, Grace. Can everybody hear us okay? Are we coming through okay? Yeah? Okay, great. So as Carolyn mentioned, we wanted to give you further background on our own anecdotal experience about how the details of an MI conversation can play out differently. Somebody who's got a significant cognitive difficulty in play. There is a fair bit of literature accumulating around how MI has been adapted with cognitive impairment, and specifically ABI and TBI. The following few slides are based on our anecdotal experience around how the conversation has been different in our own experience. So the four processes is that framework that a lot of people are familiar with by now. It's been circulating for the last 3 or 4 years. And we'll just walk you through our experience of adapting MI to in the territory of cognitive impairment. in the first process of engagement, we've discovered in working with clients with cognitive impairment that it can be really helpful to consider incentives. And Corrigan and colleagues in the States have done some interesting work around, it's really about contingency management, providing some sort of token, a gift card in one study that helps clients connect to a program or intervention. Interesting research because it indicated that clients really listed it way down on the list for factors that contributed to successful engagement. They really didn't see it as an important determinant, but the research design actually supported it as one of the top of the list in terms of influences in a person with cognitive impairment engaging. So we would do well to consider how we can bring, even though it's maybe a bit controversial, particularly in Canada still. And you know, our experience around trying to have our conversations and our care plans engineer finishing on a high note, an effective high note. So if we can finish a session with a summary that emphasizes a lot of the change talk, a lot of a person's abilities and capacities rather than the opposite, then that can really help a person come out of the session, if not remembering a lot of the content, they can remember that they felt good, and that really promotes engagement and retention in our intervention. And the other thing is, if we're suggesting out of session activities, we really want to give that careful consideration so that we're building in, you know, success and protective factors. So a person is going to more likely have a good experience rather than a not so good experience. And in terms of the second MI process of focusing, we've discovered that we, on average, have to take a much more active role in focusing. And that can look like pulling a fair bit of content from previous sessions, reminding our clients in the conversation about what they've said in past sessions and how they felt about the prospect of change. So we might have to be a lot more active in almost providing them with their memory of previous sessions, as well as previously debriefed instances where they really have had these wince moments that they may not be recalling based on a problematic behavior out of session. And we may have to actually stop frequently and do things like brief summaries, brief reflections to help keep the conversation on track, because it can veer off into tangents pretty quickly. And then the third process, MI process of evoking. One thing that we've discovered is if we're using open-ended questions, we should probably front load them with a lot of contextual information in order to kind of jumpstart a conversation that leads in a certain direction towards change and momentum towards the person feeling capable rather than demoralized. So this might be something like, so you may or may not recall from the last session, we talked about how excessive cannabis use, although it has some good things about it, it's actually putting you at the point of being evicted from your housing. How are you feeling about that now? Something like that. So really front-loading with a contextual stem. Because sustained talk, the opposite of change talk, can be really kind of reinforcing of the negative outcome. We've discovered that it's really important for us to not spend any more time than necessary on sustained talk. And the converse of that is to really emphasize evoking change talk while avoiding kind of the person feeling overtly shameful about them trying their best but not getting the outcome that we're both hoping to support them in. And the example is around somebody with a severe impairment is by definition going to need a fair bit of environmental supports. So evoking change talk with that as the target of behavior change can be a really productive thing in this context. And affirming strengths while acknowledging the limitations that arise out of a person's injury. And then finally, the fourth process of MI that we wanted to just shed a bit of light on is that we really have discovered that we're in a position where we may need to jumpstart the planning process. That might be testing the waters on planning, because if we wait for our client to do that, we may be waiting a long time. Using really meaningful summaries that captures the client's stated commitment and what they've said in past sessions about being really clear of their goal can be a nice way of sort of testing the waters on planning. This is a metaphor, creating almost like a poster, and actually maybe an actual poster. Any visual aids can be really important. That's something that I've learned from Carolyn and work with this partnership over the years, is that visual aids with incorporating content that the client has actually offered us or we've elicited from them, and then making it available to them when they really need it. And environmental supports, once again, that are acceptable to the client. You can have a menu of about 10 environmental supports that you can really think, wow, that would be very effective. But if the client's not endorsing, the top 5, then there's less likelihood that they're going to be a partner in that. Okay.
Okay, so I think
So as we were talking about before, I'm assuming you want me to pick this up, right?
Yep.
There's a big gap often between what a person will say and what they'll do, and often the way that we talk about that in our sessions is that a client's able to use their best judgment, because in the therapy session, all of the distractions have been eliminated, and you're very skillfully eliciting the correct information for the client to base their decisions on. And what happens outside of the therapy session is there may be less control with attention and memory and cognition, so that outside of the session, they're not necessarily bringing together all of the relevant information before deciding to do something. And we call that impulsivity, and that is probably a correct term to use, but it doesn't help the client understand exactly what's happening. So we talk about the therapy session being our best judgment, and now what we have to do is use environmental supports to allow the client to take their best judgment outside of the session. And so much of the intervention is helping the client to understand that gap between say and do, to take away the shame out of requiring the environmental supports, and then to design environmental supports that are accessible to the client, and implementing them at a pace that the client can really accept. So in your practice, what does executive dysfunction look like? The person who's disorganized and may not completely remember or be aware of the purpose of sessions, or have come with a completed homework assignment or logs or whatever it is that you've asked them to do. They may be late for sessions. They may have difficulty in completing tasks. When you ask them about, they'll make sweeping statements like, I intend to do this, I'll do this. And when you start to drill down into how do you suppose that might be put into action, there's a difficulty in making a plan, or the plan that comes forward doesn't quite seem practical or make sense. And then there might also be a tendency to jump to conclusions, so that one indication of something may indicate a lot. a complete change in behavior. And you see that, I think, in a lot of clients in the sense of black and white thinking or overgeneralization, just sort of like a typical cognitive distortion that you may work with in cognitive behavior therapy. But the sort that's based on cognitive impairment may be just a little bit more dramatic. The person who says, I had a cigarette, I'm going to fail completely, but sticks to that notion. Then there might just simply be a failure to initiate activity that's even confusing to the person themselves. And this is a person also who may be repeating the same kinds of mistakes, appear exceptionally stubborn, or you've made a plan and now they fail to follow that plan. So we're going to start in with the case now, and this again was a case presented to us by Natalie Brown, who I see has a question about aphasia, which hopefully we can address a little bit further down the line. So this case was an 18-year-old student who was in grade 10, and they had an ATV accident. Natalie, I'll be watching the chat bar to see if I've got anything wrong in explaining this. Now, prior to injury, he smoked 7 to 10 cigarettes per day and a little bit more tobacco in the form of poppers, and had a significant premorbid history that included some substance use, including alcohol and THC, along with PTSD, ADHD, and oppositional defiant disorder, which is a difficulty with conduct that's usually diagnosed in childhood, as well as indications of fetal alcohol syndrome. So he had a very complex and difficult coming up developmentally, and as is often the case, was also anxious and depressed. Now, he was a member in fight clubs, and that speaks to a couple of things, the possibility of lots of blows to the head, but also to kind of a bit of a rebellious, kind of oppositional way of being in the world. And what was really lovely is that he was apparently quite polite and cooperative when he arrived on the rehabilitation unit. And for those of you who may not be familiar with the process, after an injury that's severe and that results in these scattered subarachnoid hemorrhages the way that he had, they'll have a period of time in acute care where their medical status is stabilized, and for this gentleman it was 17 days. During that 17-day period, he was able to continue to smoke because there were folks available to help facilitate him going out to have cigarettes. There was a point at right around 17 days where they determined that he would be a good candidate for inpatient neurorehabilitation, and that's where the problems began. He was transferred to acute inpatient neurorehabilitation, and he left AMA after 4 days because the smoking situation changed considerably. So this is an example of somebody who, on the basis of their brain injury and the basis of their smoking, may have lost access to care. So in the process of his transfer from acute care to rehabilitation, the pharmacist started him on a nicotine patch. And the occupational therapist, because he had stated initially that he was wanting to smoke, started out with trying to help him find his way to the smoking area safely. But he was very distractible outdoors, and he wasn't able to follow the rules that were associated with the smoking trips. Now, in the first 4 days, the family and friends took him out for smokes, but they lived too far away and they had to leave. And the interdisciplinary team was very concerned about him leaving AMA, so they really prioritized helping him to get out for his smokes. But ultimately, that wasn't as successful as they would have liked to, as they might have hoped. And so during the course of all of this, he made the statement that if he wasn't there, if he was still at TRI in a month and he wasn't able to smoke, he was going to punch someone. So people were really concerned about what his behavior might become if he stayed on the unit without access to smoking. So again, the goal of helping him to get to the smoking area was made a priority. So they allowed him to take independent time They did some harm reduction or risk mitigation by, giving him a card and helping to make sure that if he did go out, it wasn't a dangerous situation. And there was discussion with the physician and the pharmacist regarding breakthrough and craving management. But the patient didn't like his patch, and he removed it. So the outcome of the situation was, and why this was brought to our attention, is that he made it clear that he was unwilling to remain, and he left AMA. And as a result of leaving AMA, under those circumstances, he, as is often the case, there was a lawyer, and there was some funding for private therapies, but he had refused those. He was couch surfing. His sister attempted to get him supports, but that wasn't successful. And throughout all of this, he kept a nice, calm demeanor, but he was refusing services. So for this potential takeaway, I guess they wanted to look at alternatives. So one question that came to mind is, how could you introduce nicotine replacement? And this might be a question that we want to pull Dr. Selby and Tim in on. How would you introduce nicotine replacement to a person who doesn't have the goal of quitting smoking in order to help them to benefit from a therapy, a set of therapies that they may not be fully aware that they really need yet? And when to start NRT, whether they're in the acute phase or afterwards, and if there are any other alternative interventions that might be suggested. Do you guys have any comment on those things?
Yeah, I mean, I think, at first blush, I think we need to think about engaging the person in whatever the plan is and understanding what their goals are in terms of what is it that's driving them. I think that's key. And sometimes, we have to look at what their motivations are. What are they willing to do? Are they willing to put the patch on and smoke with it? Or we told them take the patch off because you can't smoke with it, and so they take the patch off because they know cigarettes. So, some part of it is to really think about how are we communicating with the person, how are we engaging the person, as you pointed out, and are you saying this is about quitting smoking versus managing acute withdrawal when you cannot smoke when you're indoors? Very different approach to this. So I think that that would be an important way to think about it. And again, if the patch is something that he impulsively takes off, or he takes it off sort of with some planning, then some decisions can be made as to where the patch is put, so that it's not easy. It's not just comes into his line of sight and then he yanks it off, versus it's applied every morning on his back, so he doesn't know it's there, and he doesn't sort of get reminded through the day that it's there, but it's there. So there are some sort of minimal things that we could do to better understand. But really the key issue is differentiating between quitting versus withdrawal management, and sort of, I hate to use the word harm reduction because we're really looking at managing his withdrawal, and then managing impulsive behaviors that get him to yank off the patches.
And I guess further to what Peter said, I think about, given he's 18, his developmental phase, what values does he hold that connect to any sort of goal around smoking, doing anything about his smoking? Because as an 18-year-old, even without any sort of impairment operating, an 18-year-old's values are much different than adult values. I think it makes sense to really explore that, to find out from him why he would be even interested in entertaining any sort of goal, and how that is connected to a cherished value or life goal that he holds dear.
So the issue is then connecting the nicotine replacement to some goal that the client themselves has, and if they don't share the same goal, overtly acknowledging that, and trying to find the common ground. And if one thought that I had in looking at this case is that the best alternative in terms of his therapy might be inpatient. but we might, we have to be considering that this is a kind of a rebellious guy. He's an 18-year-old. He's not sharing the goals. And so one element of risk mitigation might be to reconsider the referral to inpatient rehab if you can't come to some agreement on the smoking, so that you can ease him into an outpatient therapy, and doing that overtly as a concession to him, letting him develop some awareness of the brain injury-related impairments, and then possibly putting him in a position to, down the line, appreciate the need for an inpatient stay, if that makes sense. Natalie's got a comment here. He felt that the only thing he had in his Aboriginal communication, okay, so they were talking about the patch being applied to the back, and what we found is that if it's not there and you can't and you don't feel it, and it draws less attention, then it's less likely to be just taken off impulsively. So yes, you always have to get an informed consent, but placing it on the back may reduce the likelihood of that impulsive behavior. And then there's another comment. Does a TBI client have the capacity to refuse nicotine replacement therapy? And the answer, of course, would be yes. And I think, Natalie, you're talking about in relationship to smoking, that in terms of his value, he felt it was the only thing that he had in the Aboriginal community that he came from up north, left to him was the smoking, and so deprived of that, it was a deprived environment. They had no running water and no heat. So holding on to the smoking, if I'm understanding, was an important value for him. Traumatic brain injury is TBI. I'm sorry, Diane.
Right. So traumatic brain injury, acquired brain injury are sort of used. Are there any significant differences between the two, Carolyn?
Traumatic brain injury refers specifically to those that are developed, because you had to force a blow to the head.
Right.
And acquired brain injury would be something like a tumor or a stroke that might be related to something medical. And I think very often folks might be dealing with anoxic injuries that are related to, say, overdoses, and those are all acquired brain injuries. Right.
So I think, part of this issue is that even people with these conditions have contextual issues. So, we're seeing that he's using cigarettes as a way to connect to his Aboriginal community, but we know that it's he may or may not be able to appreciate this, but the commercial use of tobacco is very different than the traditional use of tobacco, which does not involve cigarettes, does not involve commercial tobacco. And so depending on where his identity is and how connected he is to his community, getting an elder involved or somebody local involved in helping him see that might be one way for him to see the difference between traditional use of tobacco and commercial use of tobacco. Unfortunately, because of the pervasive use of commercial tobacco, he may just, not withstanding the cultural norms, the societal norms in which he finds himself will opportunities, and if his executive function is compromised, refusing those cigarettes may be harder for him because he's unable to exercise what we would call response inhibition. That means inhibiting his response in the face of a craving. So therefore it becomes hard, for people in that situation. But given where he's at, looking at the safety plan for risk, part of it is, with people who have compromised cognitive function and executive functioning, cigarettes can be really dangerous. We've had cases in Ontario where in nursing homes, people who've been compromised because of an ABI from a stroke in a nursing home were, left when they used to have smoking rooms, left in the smoking room with a cigarette. The cigarette fell on that person. The person was aphasic, wasn't able to call out, and got burned to death. Or somebody who sets a house fire because they don't understand or appreciate the risks involved with smoking in bed, or flicking their ash on the carpet below, or stubbing, leaving a cigarette lit that rolls off and catches, sets the house on fire. So, the risk, especially with people with compromised brain function, is more than the long-term, in addition to the long-term risks from tobacco, are these immediate risks that we often don't consider, which are fire risks.
Mm-hmm. And we do see that a lot with our clients, that we kind of encourage, it's easier to encourage cessation, oddly, than it is to modify the behavior. Because while the stimulus is still around, the likelihood of impulsivity is greater. But when you get them to quit, and you celebrate the quitting, you have all of the built-in replacements, and that trigger for the impulsive behavior is now absent.
Yeah.
And so we've kind of been converted to the idea that environmental supports to help a person quit, using the motivational interviewing strategies that we've talked about to help them accept the environmental supports. It often takes a very long time. Working with a couple of the guys in our residence, I want to say 3 to 6 months to get a person to be in a place where they'll accept the presence of the patch with smoking is kind of what I'm starting to understand is the norm. So it's quite a protracted process. Can I call attention to Natalie's comments here?
Yeah.
It says that she didn't have the opportunity to pull in an older, but that would have been an excellent idea had he been willing to stay longer. And I guess most of the time when we look at these things, it's 20/20 hindsight so that we can prepare for the next difficult thing. So it's something to consider about the interface between the transfer from acute care into, especially for these teenage kids, into the rehabilitation programs, if there can be some sort of early warning system to look at the kids who might have greater difficulty in adapting to that situation and doing some specialized planning, but they'd have to be identified by that acute team as somebody in need of that kind of planning, and that might be a difficult thing to do. Marinka says, can you suggest some realistic environmental supports for a patient with TBI, ABI that lives in a continuing care facility? One of the things that we've started to understand from our point of view is that it is helpful to initiate the nicotine replacement therapy if they're smoking enough. It doesn't help if they're not. Thanks for moving that forward. If we look at whether or not the behavior is driven by a behavior pattern and self-concept, or is it driven by actual withdrawal? And this fellow that we have here, he's smoking 7 to 10 cigarettes in a day, and we don't know how addicted his pattern was, but probably it was more based on his self-image and being told not to do something than it was based on actual withdrawal. And so in that circumstance, you really want to be doing everything that you can to increase choice and autonomy, and framing in some way the reduction in the need to comply with rules around smoking as a means to an end that he appreciates. And in the absence of that, it's really difficult. When we've had folks who are smoking in places like long-term care homes, we use the safety, first of all, inflammable bed or non-flammable bed clothing, and ashtrays that are self-extinguishing ashtrays. So some of those environmental supports are there. Holding the client's cigarettes to ensure that they are only smoking when they're in the presence of somebody else. And sometimes it's contingent on their living in a certain situation. And the difficulty is health and safety, having somebody observe them while they smoke. So you have to be in a well-ventilated area, and they have to be allowed to smoke, and the person who's watching them smoke has to be able to maintain their own safety from the secondhand smoke. So it does get very complex, which is why we started looking at incentives for stopping smoking. So sometimes if you can start the patch and the cravings are reduced, then you can start to introduce, if instead of the smoking we can do this other desired thing, then you can sometimes increase the likelihood of somebody buying into the process of smoking cessation.
So I think this slide here just summarizes a way to approach the complexity, because the issue that we want you to walk away with is that taking a simplistic approach will not help. And so what are some of the environmental influences that might help and help him stay, as well as help him not, smoke? So I think Carolyn spoke some of it. And then really looking at the behavior issues and how do you keep those positive interactions, as Tim was saying, so that he feels connected, as opposed to, with this opposition to authority, if the no, you can't smoke here, that kind of language keeps coming in, often you will get the oppositional behavior, which is leave, and primarily less appreciation of the consequences. And as we've said, is if he has been diagnosed with FAS, fetal alcohol syndrome, he's already coming in with a compromised brain in terms of a fixed encephalopathy, in the sense his ability to appreciate and the consequences of his behavior are diminished. Then he's an adolescent, plus a brain injury, plus withdrawal. You're dealing with somebody and other psychiatric conditions. So it becomes very difficult for a person like this to make reflective decisions or engage in reflective thinking. Decision making is often going to be very impulsive, and so, not precipitating these kinds of activities is going to be a key feature. Now, of course, it's not always in your hands, because it's the nature of the condition. There will be impulsive behavior, there will be people who leave, but interestingly enough, I think if you can keep that they have had positive interactions through all of this, they may come back for another day. So keeping a view of the long game is going to be critical. I'm conscious of the time, and I just want to make sure we go through the other the other issue is that when you take a look at readiness, you may not have anybody who is ready, wants to continue to smoke, and the only reasons to sort of reducing or addressing it is that they need to access inpatient services. So all of this for triggering cessation is an externally motivated thing. It's not necessarily internally motivated, but there are restrictors which can help reduce it. So we know that if people are in tobacco-free, where there's no cues, there's nobody smelling of tobacco, there's no tobacco there, you're less likely to have people wanting to go seek out cigarettes, because at 7 to 8 cigarettes a day, the person is not physically dependent. It's primarily driven by historical or habitual issues, or, as we said, some of the psychological issues about being oppositional or controlling, and possibly also trying to mitigate some effects of the medications they're on. We can't use medications like bupropion or Champix because of the history of seizures, although one would use Champix if you had somebody who's motivated and wants to quit, or at least is willing to take the medication. And again, the other thing is that inpatient units can become pretty overwhelming if you've got different staff, different changes, different people making the requests of the person. And so you could see how people can sometimes just sort of, disengage, because the only thing they feel they have control over is their smoking. So there are some challenges that come up in those situations. What can we do? So can we take a harm reduction focus, management, keeping the person engaged? I think, Tim, that's the key issue, keeping the person engaged, breaking it down into chunk size, linking it to something that they value, and making small, consistent steps towards that goal. So if he's using nicotine replacement and going out and smoking, not taking the patch out or not, but creating a count so that you can see that his over time is and rewarding him with incentive if he's able to reduce. So looking, and again, that we talked about the escort outside. That's purely a pragmatic, keeping it safe, nobody dies, but also, as Carolyn said, mentioned, don't let them get exposed. Again, I think you've talked about this, that we need to emphasize areas of choice and increase availability of preferred activities. And again, if you can just talk about what FFS rehabilitation aid is. Mm-hmm. Carolyn, what's the FFS?
Oh, fee-for-service rehabilitation aid. So if he did have access to some funding, then in that transition between acute care and the rehab hospital, hiring somebody who could actually serve as a smoking escort. And doing that as a part of a contractor plan overtly with the client.
Yeah, so I think if you look at the other areas of the case, you can see that there are so many factors to manage, and essentially, pick one and start working through each one, because no single intervention is going to make this any better. So. Part of this is, and Carolyn, you've taught us, is that you need to have a comprehensive program around this person, consistency of message, management of all the comorbidities, and this is what makes it complex. It's not, it's not a simple condition, and you always have to make sure that the person is able, has capacity to consent or not to what's being done, and it's decision specific sometimes. So thinking about this in this complex way would be very helpful when you are faced with something like this.
And it's going to take some time with somebody this complex, and there's going to be lots of false starts. Yeah. But relationship can be really important, and it can be very unpredictable in terms of when that. When your relationship credits that you've invested in are going to pay out in terms of more openness to a really meaningful environmental support or compensation strategy being implemented.
Yeah, and I think Natalie rightly points out, saying that, you've obviously done some staff training around wording about supporting craving rather than helping you quit. We talk about autonomy support. And again, especially when people are in that adolescent age with head injury and addictions, supporting autonomy becomes even that much more important. But at the same time, making sure that we can express the empathy around it.
Well, what it could look like too is avoiding arguments.
Yeah.
Rather than looking for a roses and sunshine type of relationship.
Right. So just to quickly we're over by a minute, but I just want to make sure we sum up, is that when people's brains are compromised, environmental, and even when they're not, environmental intervention is crucial, especially if you can reduce the cues and triggers and capabilities and opportunities to use tobacco. Sustained talk doesn't mean the interventions are off the table. You still have to continue with that. Target of intervention is increasing the acceptance of the environmental change and actively seeking to make the environment more acceptable, so engaging them in that environment. And it might involve distraction, it might involve rewards that are nudged and keeps the person away from seeking tobacco. Although change talk is necessary, it's not sufficient, that there's going to be a behavior change. In the moment, feedback and reinforcement is helpful in an empathic, engaging way that keeps the person engaged in the activity. Again, an off-label use of NRT, especially in heavily dependent users, might be needed. I mean, in this person, we don't know for sure, but usually people with First Nations heritage might have lower rates of the number of cigarettes they smoke per day because their metabolism may be slow metabolizers of nicotine. We don't have a test on him, but given that if he's always smoked 8 to 10 cigarettes no matter what, one can reasonably assume that he's a slow metabolizer. And therefore, one would make sure we don't give him like a 21 milligram patch. And then again, looking at harm reduction strategies, whether it's bringing a fee-for-service support worker if there's funding for that, and then planning for the outpatient care when the person leaves. So, I think we really need to close this, but we need to just talk about the question is what happened to him after he left, and and I think the last question you have, Natalie, is that his sister says he's couch surfing and using poppers, cigarette stuff with marijuana, and again, this is that goes back down to engagement. How do you get him back into an outpatient program that has structure, that he wants to attend, where this is going to work?
Yeah, what's going to have the most meaning for him in re-engaging?
In practical fact, what we've known in terms of outreach services is it's rapport. So it's going in with that good MI sort of spirit about you and figuring out what is the client's goal. There's a strong likelihood that there's something happening that he's unhappy with that can be addressed, and then taking a harm reduction approach to all of the substance use as you move very slowly to get engagement and then ultimately move a person towards a more active role in their own care. But it really does start with the engagement and often hinges on rapport.
And again, I guess if I understand, if he's on reserve, is there a way to engage with the, provide either telemedicine or other supports up there and engage the community model to help him, recover? And again, that may or may not be feasible, but just some thoughts about having a creative way of assisting somebody, and what are the assets that are available to him with addressing his use of substances.
One of the nice things about the northern environment is the brain injury services tend to be highly integrated with mental health and addiction services. So there's only one or two providers. And so the Brain Injury Association of the North, and Alice Belafonte is the executive director up there, might be able to, like a call up there might be able to connect you with some providers that are aware of these complex issues. So it is, even in those remote places, it's you have to know who to contact, but there are some services available, and they tend to not look like Toronto-based services. They tend to be a lot more organically developed within the community, and in some sense more integrated, because there are fewer providers, and because there are fewer providers, there are fewer sort of spaces between the programs. And again, because it's remote, if a person's really in a very remote community, they may only get visits very periodically, which can be unfortunate. But areas that Thunder Bay and its surrounding areas, there are some support services available.
So I just want to just wrap up for today, because I know we are over and a number of people are leaving. We have a lot of questions, and this seems to be a great discussion, but I do want to thank everybody who attended and thank our facilitators, Carolyn, Tim, and Peter, for your presentation today. Just a reminder for our participants today that a link to the evaluation and post-learning assessment will be sent by email today by 4 p.m. You will have 1 week to complete the post-learning assessment in order to receive your letter of completion. If you attended today's session as a group, please be sure to email teach@camh.ca with a complete list of participants by 2 p.m. For those who are interested in attending our next session, it will be on Wednesday, March 22nd, and it is a two-part series, so part 2 of the complex client journey. The first part took place last month, and an archive to that webinar can be found on the TEACH website. If you missed the beginning of today's presentation or want to view it again, no problem. You can view this on our website at www.teachproject.ca under Teach Educational Rounds, Archive, and Self-Study. Thank you again to everyone for attending, and we hope you have a good rest of your afternoon.
Thank you.
Bye. Thanks so much.
Thank you.
Everybody.